Welcome from Barcelona. My name is Bart van der Worp and I'm interviewing Professor Dan Hanley from Baltimore in the US, who presented yesterday the results of the CLEAR-3 trial. Professor Hanley, could you please explain what the background and aim of this study were?
Sure. One of the severity components of brain hemorrhage is interventricular extension. And CLEAR is one of, I think, 4 trials we've done that are directed at trying to mitigate or relieve the effects of interventricular extension.
So, and how did you address this question?
So this is a phase 3 trial, and we thought we understood the proper dose of a medicine to remove the clot. So we went forward attempting to show whether or not functional change measured by the Rankin score was improved with the treatment, giving alteplase in very low dose, so giving a clot-busting drug in low dose and seeing if it removed the clot more rapidly and if that benefited the patients.
Yeah, and how many patients did you include?
So this is 500 patients with a 1-to-1 randomization, so 250 in each arm, actually 251 in one and 249 in the other.
Okay, and these were all patients with interventricular hemorrhage?
Correct. So the inclusion criteria made it so that they had so-called large IVHs obstructing the 3rd and 4th ventricle and small ICHs under 30 cc's. The median is about 8 cc's.
Yeah, and what was the time window for inclusion?
Up to 72 hours after the ictal event, you were allowed to enroll the patients. I think the average enrollment was at around 48 hours.
Yeah. And don't you think this is a very long time for an acute stroke trial? Don't you think much of the damage will already have occurred?
Yeah, that's what we would have thought, but in our preliminary studies, we didn't find any time dependence to either damage or the possible mitigation of damage. So it's much more efficient to run the trial with less waste if you include all people who might benefit. So that's what we did.
Yes. So what were the results of CLEAR-3?
The results for the primary hypothesis were neutral. We showed only a 3% improvement in the proportion of what we called good outcomes, which is the Rankin 0 to 3 scores in relationship to the proportion of bad outcomes, the 4 to 6. So it was neutral, and we did not prove the hypothesis that the active intervention arm, alteplase, improved things.
Yeah, and was there benefits for other outcomes?
Yeah, absolutely. Almost all the secondaries demonstrated a strong indication that there is benefit to this approach. The first secondary was mortality, and both in the subsequent analyses of the Rankin score and in a separate all-cause mortality analysis, there was a 10% difference at 180 days and at 365 days.
So patients treated actively had a larger chance to survive, is that correct?
An absolute difference of 10%.
That's a major difference. So what do you think the implications for clinical practice should be?
I think the other secondary that's important to talk about is a sort of per protocol or efficiency of removal analysis, which we pre-specified. And that shows that much larger changes than the 3% we found are potentially possible if practice changed and if the responsible physicians in each case embrace the goal of getting 80 or 90% of the clot out. And we hold or continue to hold the hypothesis that both mortality and function will improve if you can perform at that level. So given that constellation of 2 major secondary findings, the mortality finding and the mitigation finding, we think we do need to do another trial. We note that the EVD practices, how they're used, how often they're used, are not well defined in the guidelines, but we've collected enough data to begin to suggest what those practices should be and how they should interrelate to the goal of clot removal.
Yeah, researchers more often say that they should do more research. So what would you do before this new clinical trial will start if you have a patient with a large interventricular hematoma?
Yeah, I think because we live in a time of equipoise here, the big concern that people from outside our group have expressed is that if the only benefit is mortality and the possibility of increased disability exists, that maybe it's not a treatment that can be recommended. So I think one has to go to the individual patient and family and decide what's best given the knowledge that we've put forth. And I personally would accept a wide range of decisions: treatment with alteplase, treatment without, or no treatment at all, which is the single most common thing that's happening both in Europe and the United States at this time.
And do you think that the larger risk of death in the control group might have been caused by, for example, more withdrawal of care in the control group and not in the active treatment group?
That's a great question. I think we both know that withdrawal of care is an important variable. We tracked it, and we tracked the reasons for withdrawal of care, and we didn't find a difference in the two groups. So fortunately, we believe that it's not related to that.
Okay, so to conclude, treatments of patients with interventricular hemorrhage with alteplase does not improve functional outcome, but it does have give rise to an increased chance to survive.
In a secondary analysis.
In a secondary analysis, but still.
That's hypothesis generating if we use all the rules of clinical
of course.
trials.
And the findings should be confirmed in a new trial. Would you be willing to lead the trial again?
Absolutely.
Okay, that's the best.
Clear for, clear more.
Okay, thank you.
I have the energy and the time.
Thank you very much.